In addition to spleen reduction, obviously patients experience improvement in their symptoms. Fatigue is a hallmark of patients with myelofibrosis, where like more than 80–90% of the patients will have major fatigue that interferes with daily activities, bone pain, weight loss, and patients derive a significant clinical benefit from treatment with ruxolitinib, which actually can be seen earlier than even spleen reduction. Typically, patients will start feeling better within a week to 2 weeks on treatment in terms of symptom improvement, while spleen response may take 3 to 4 months to get the maximum benefit of the treatment. So those patients with splenomegaly or constitutional symptoms benefit from ruxolitinib treatment, which really had become the standard of care for those patients. The treatment is associated with myelosuppression, namely anemia, particularly at the beginning of the treatment, where the nadir of the counts is typically by the second month of treatment. So sometimes we need to do those adjustments, or if the counts were borderline, we start with a lower dose. And sometimes we have those discussions with the patients to decide on which is the major important symptom for the patient. So for some patients with large spleen or constitutional symptoms, they could tolerate transfusion at the beginning while their symptoms are improving. But if the main presentation or indication for treatment is cytopenia, then ruxolitinib is not the treatment of choice for those patients. And another point, obviously, there is always a misbelief that the patients have to be JAK2 positive to respond to ruxolitinib. In reality, the JAK-STAT pathway is overactivated in patients with myelofibrosis in presence or absence of the JAK2 mutation, given other mutations that activate the pathway, or just by the cytokine release. So patients will benefit from ruxolitinib treatment regardless of the JAK2 status. We've had long experience with those treatments now. The two studies have demonstrated a survival benefits for patients that were treated with ruxolitinib, although the two studies were not designed to look at survival advantage, and the study design allowed a crossover design that makes it more difficult. But patients that were treated with ruxolitinib did have better overall survival. When I discuss that with patients, usually the indication for the treatment should be symptoms. So we don't treat patients with the treatment to try to alter the natural history or improve survival, but those patients that are symptomatic with the splenomegaly or constitutional symptoms will drive survival advantage from the treatment. In general, ruxolitinib is well tolerated. Myelosuppression can be observed, particularly anemia and thrombocytopenia. The nadir of the counts usually is around the second month, week 8. So when we start patients on treatment, we check their counts either every week or every other week, and we adjust the dose accordingly. If the counts are borderline, we may start with a lower dose and quickly escalate to the appropriate dose based on their counts. Other than myelosuppression, sometimes we do see non-specific symptoms such as headache, dizziness. There is increased incidence of urine tract infection and herpes zoster reactivation. We don't typically do prophylaxis, but we observe for those. Ruxolitinib does have some immunosuppressive effect on the T cells, and that's why now it's actually approved for patients with graft versus host disease. However, on long term, there had been very rare cases of infections such as TB reactivation or PML, but those are very, very rare. I've not seen them in my experience. So in general, patients do feel better with treatment, and my experience had been positive with the treatment. I think one has to be aware of the right patient selection for the treatment, adjusting the dose and monitoring for the side effects. One other important point is some of those patients sometimes get admitted for other reasons, such as infection, other procedures, complications. One should not stop the treatment immediately, because if the treatment is stopped immediately, the patient's symptoms return quickly within a week, or they could get or feel more sick. So usually we try to tell the patients to continue on treatment, and if some reason they are not able to take the treatment, sometimes we use steroids because the patients could get sick on the short term if they stop the treatment immediately. For a subset of patients with cytopenia, namely anemia, treatment is more challenging. There are not many options available for those patients. Sometimes we would use erythroid stimulating agents where responses are low. Immune modulators such as thalidomide and lenalidomide are used for cytopenias. However, again, the response rates are low. Danazol, anabolic steroids are used for those patients. Unfortunately, many of those patients with cytopenias will become transfusion dependent.